Hi, good evening, everybody. Welcome to another session of webinar, and this time again, we are collaborating with Beacon Hospital, and Miss Yoon Suk Yi is actually a genetic counselor. Will you say that? Yeah, and she's with Beacon, so she will tell us more about whether cancers are hereditary, and I think it is a very important aspect as cancer is becoming more and more common, and we see it. But without further ado, we invite Miss Yoon Suk Yi. I'll call you Suk Yi, yeah?
Yes, thank you so much.
Yeah.
I'm just going to start sharing my screen. Right. So thank you very much for the introduction, Dr. Betty.
No worries. Don't just call me Betty.
Good evening, everyone, and thank you for the invitation to speak here today. Thank you for sharing your evening with me while I tell you a little bit more about hereditary cancers. So my name is Suk Yi, or Miss Yoon, as some would call me, and I'm a genetic counselor. So that's not often heard, but there are a group of us here in Malaysia, and basically we work with genetic diseases and the predisposition or the use of genetic information to inform us better and to have better ways of managing diseases that are from genetic origins. So what I'll do today is touch a little bit about generally how does cancer occur in the first place and why the genes come into play. And then we'll delve a little bit into what hereditary cancers are. And with hereditary cancers, how do we actually identify them? How do we know if someone has an inherited cancer? And that's when there are uses for genetic testing. And what are the criteria? How do we choose who to test? I'll move on then to the utility of this test and how it can actually help us make decisions on treatment options and what we can do with risk management. Zooming in particularly on breast, ovarian, and prostate cancer, because these are the more common ones that have an inherited component. I'll end with 2 case studies to demonstrate some use of genetic information in certain family structures. And it's also an introduction to how we look at pedigrees and use that as the basis of deciding what to do in terms of risk management and treatments. So how does cancer occur in the first place? So understanding about cancer requires many angles. That is always the biggest question for a person who has had cancer in particular, or caregiver who is looking after someone with cancer. What is the cause, right? And unfortunately, because it's such a multifactorial disease, sometimes it's really hard to pinpoint exactly what has caused the cancer. The questions would be, can it be prevented? And what is the link between genes and cancer? So all cancers derive from single cells. They don't just appear, they do come from normal cells. And basically, they are normal cells that have acquired this ability to be, in some cases, immortal. A way of saying that they divide continuously, it's unrestrained, and it has the capability of invading surrounding tissues. And that's what we always use the term metastasize. So the cancer cells behave in this abnormal manner, and that's because there are changes in the DNA sequence of the key genes. So the message here is that all cancers are genetic diseases. They start with genetic alterations, and that has to be the beginning of how a cancer can occur. Then, of course, the question will be, where do all of these genetic changes come from? And that's something that we will talk about in a little while. So I want to introduce the concept of 2 different genetic terms, right? Oncogenes and tumor suppressor genes to follow. So basically, for genetic changes, we do look at what we call, you will hear of the term oncogenes. Basically, these are when they are not driving the cancer, they're sometimes known as proto-oncogenes. So they regulate cell growth. So if they are working well, our cell growth should be regulated. These are what the genes are meant to do. Right? But what happens is when there are genetic variants, right? Variants meaning there are changes to the DNA sequence. And if these particular variants can cause the function of these genes to change, so they are like sort of an accelerator. You've caused it to move the cell growth and cell division even more. So that causes the normal cell to then become what we call a malignant cancer cell. How about another group of genes? So they're usually known as tumor suppressor genes. These are genes which usually what we call genes that prevent cancer, as the name tells you, tumor suppressor. So they are usually DNA repair genes in different pathways. And what happens is that it corrects and repairs DNA damage in different ways. And there are different processes in which this DNA damage can be repaired. So these then become essential genes for the repair. So if these genes have damage, again, if they are variants, apologies, there's a background sound.
Sorry.
I'm not sure where that's coming from.
Hold on, can you, oh my God, I just don't know how come.
It's gone, so it's fine now. Right, so when it comes to tumor suppressor genes, again, if there are variants in these genes, and these variants, there are different types of variants. So if they are known to cause these genes to lose function, so this gene must lose function, then it can be activated further with a second loss in function of the second allele. Then it no longer is able to prevent or continuously do repair the DNA damage. So this is another way where the cell then becomes a mutant cell and it can then lead on to cancer. So just to give an introduction to what some of these genes are, so you can see that oncogenes are in different classes, which are usually the growth factors in these pathways. So some of the ones which may sound more familiar to some of you, like the HER2, EGFR, BRAF, and so on. Then if we look at the tumor suppressor genes, just to introduce some of the names of these genes, BRCA1, BRCA2, or more well known as BRCA, we have p53, we have RB, so on and so forth. So there are many genes that are well known and well evidenced to be in the pathway that, if disrupted, will cause the onset of cancer. So now let's then think about, we now know that all cancers are of what we call genetic origin. So all cancers are genetic diseases, but not all cancers are hereditary. Not all cancers are inherited. In fact, less than 10% of common cancers are hereditary. So if you look at this pie chart, it describes sporadic, which are majority of cancers, and then we have a familial component and a hereditary component. So not familial means there is a pattern of cancers in the family. Not necessarily it is inherited. It might just be a particular group that has a common shared group of genes, right? But hereditary means there is a faulty gene that is passed on from generation to generation. So you can see that it's actually only about, it's less than 10% of most cancers. But there are many, many types of hereditary cancer syndromes. And why do we call it syndrome? Because a particular faulty gene may cause an increased risk to more than one kind of cancer. So some of these cancers group together, they cluster. So that's why most of the time we call them syndromes. So typically, they are due to pathogenic variants in tumor suppressor genes or repair genes or mismatch different types of repair genes. Okay, now I highlight the term pathogenic here because not all variants in these genes can cause hereditary cancers. Variants are classified in different ways, and it has to be pathogenic, meaning it has to cause a loss of function before you will see the risk due to these genetic changes. Mostly autosomal dominant, meaning you only need one copy for the risk to show. And what makes it complicated is the incomplete penetrance of the risk from these genes. What this means is that someone who has this inherited faulty gene will have an increased risk to cancer, but it's not an absolute risk. So it's not 100% like some single gene disorders where if you have a faulty gene, the disease will manifest. For cancers, they are varied. Some have a higher penetrance. So there are certain genes, for example, inherited germline p53 mutations will cause almost a 90 to 95 penetrance. Where else, something else, for example, say BRCA even, it's a range between 40 to 60 for BRCA1 for breast cancer risk. So the incomplete penetrance makes it a little bit challenging in terms of managing risk, because then it means there are other determinants on what the absolute risk will be and not just entirely reliant on the genetic variant. So some of the more common syndromes that you may have heard of. So BRCA1 and BRCA2, which accounts for around 5 to 8% of all breast cancers, if you don't take into account any of the risk, a priori risk. Lynch syndrome, previously known as hereditary non-polyposis colorectal cancer, because it was found more in colorectal cancers, and this is about 2 to 3. So it depends on the population as well. So it can be up to 5% in certain populations of colorectal cancers. Something which are rarer or less common would be Li-Fraumeni syndromes, where they are due to inherited p53 mutations. So these are rare. FAP, these families are rare as well. And so on and so forth. Cowden syndromes, Mendes, and HTGC, these are rarer in a sense. So you won't get up till 5%. It's probably less, about 1 or less in terms of the number of rate in the cancers. So I'd just like to describe over here when we talk about hereditary cancer syndromes, right? On the left are the column on the left are the genes that if there are pathogenic variants. On the right are a list of some of the cancers that are associated with these genes. So as you can see, depending on which gene has a fault, then the risk of the cancer profile is different, right? So if you look at BRCA, BRCA, you see it more breast, ovary in women, breast or prostate in men. Sometimes you see pancreatic as well. If you look at Lynch, for women, you have quite a few more risk profiles for breast in some cases, but majority would be colon, uterine, ovary. Then in men, you'll also see more in colon and so on. So as you can see, each syndromic gene per se has its own cluster, right? So when we talk about hereditary cancers, these are the things that we look out for. If you start seeing clusters of cancers of sorts, so that should raise some questions about whether something is happening that is inherited in the family. So how do we find these or identify such families? How do we know that there is an inherited risk or if someone has hereditary cancers? So there are genetic tests that can be done, right, to ascertain. But before we go into the genetic tests for hereditary cancers, I find that there's a very common misunderstanding about generally what genetic tests are. So I'll just like to take a little bit of time to introduce what we call somatic testing and germline testing. So somatic testing identifies mutations that are in the tumor, so acquired changes. And we all know that all cancers must have genetic changes in the cell, right? Before it can, before a normal cell can become a cancer cell. So these changes can either be acquired or they can already be there in a sense, germline. So when we talk about a somatic test, we are testing those that are in the tumor. Okay, so it's always performed on a tumor tissue or circulating DNA. Yeah. Where else, when we look at inherited genetic changes, these are what we call germline. So germline genetic testing. So it is looking for variants that are born with. So it is already there at birth. It is passed on from generation to generation. So it's either from your father or your mother. And this one is always performed only on blood or saliva. So if someone does a test from cancer tissue and they say that they have found a mutation or a variant, and that must be the reason for the cancers in them and the pattern in the family. So that is not accurate in a sense, because you will need to make sure that it is confirmed in either a blood or a saliva source. So for germline testing, you can either have it done on someone who is affected, meaning someone who already has cancer, or someone who is unaffected. So someone who doesn't have cancer can be carrying these germline genetic changes. Whereas for somatic changes, it has to be someone who already has developed the cancer. So it has to be from a tumor source. So when we do testing for somatic profiles, and we'll hear of that later, because more and more treatment requires these somatic profiles to match. And that's where we are moving into precision medicine targeted therapies. So with somatic changes, the result may change from time to time, and sometimes it requires a serial testing to look at progression. So some of the tests that are used for therapeutics would be some of those listed here. They can either be to plan for treatment or they can be for prognostic purposes. So usually, because these are somatic, it doesn't require pre-test genetic counseling, unless you find something that is in one of the high-risk genes, then you will refer on for germline testing, and that would require genetic counseling. So in terms of germline, it usually does not change over time because you are looking at something that is inherited, right? So usually you only test once, but the number of germline genes, in the sense that you can test, increases over time. So we know more and more, we have more access to new data, there will be more things that you can test. So a repeat test usually is to look at newer genes and not so much to correct the previously done test. So some of the tests that are for germline would be to look at inherited risk. So we can look at all of the genes that I've mentioned earlier in the earlier slide. So all of those can be tested with germline. And it is highly recommended for pre-test genetic counseling before germline test is done. And we'll come to that in a little why that's important. I would just like to then highlight a term that is used very commonly now across the board for all types of genetic tests. So in cancer in particular, we now hear a lot of the term next generation sequencing. Sometimes they would call it, oh, I did an NGS test, so it was very expensive and so on. I just want to highlight that this is currently trending, but basically next generation sequencing is just a technology platform. It's just a way of how we can sequence in what we call a massive parallel throughput. That means it's high throughput. You can look at many genes at one go. And so all kinds of tests can be using next generation sequencing. So it can be a somatic test, it can be a germline test. Yeah, it's just that the way I think it's been marketed, it's always it seemed like, oh, people come to me and say, look, I've done an NGS. So that doesn't mean very much. It really depends on what it was used for. So there are benefits and pitfalls to using such new technologies where you can sequence hundreds of genes at one time. Benefits are that you can save a lot of costs by looking at many genes at the same time. You can get a lot of data and discover a lot more variants. But the pitfalls are actually very much in the interpretation of this data. It doesn't mean that if you test more, you will get more. You may test more, you will find more uninterpretable data that might leave you even more confused, sometimes misinterpreted. And if that leads on to a medical decision that may be due to misinformation or misinterpretation of this result, then that can be quite dire. So just to highlight that new technologies, new platforms that derive a lot of new data doesn't mean it's better. Sometimes you still have to focus on the genes that you know well and are evidence-based. So that comes to what I want to talk about next. So there are guidelines. There are guidelines on how we want to work with hereditary cancers, meaning who do you test? There are actually many guidelines for many different clusters of cancers. I have put here an example of a very large group of cancers, which is very common. So hereditary breast, ovarian, prostate, and pancreatic cancers. And the NCCN guidelines are what most centers or most services reuse. And basically what it does is it lists down individuals whom you should pay attention to think about testing. So for example, it will list down if it's a breast cancer patient that is diagnosed 45 years and under, then you should think about it. If it's someone who is a little bit older but has a second breast cancer, or what we call contralateral breast cancer. If it's someone who is 60 years old and has a subtype like triple negative breast cancer. Now, bearing in mind, this is an American guideline, but it is used loosely throughout the world. So they will even have it by ancestry. Right. So group 1 is all about breast cancer in the family or in the individual. Then you can have individuals who have multiple cancers. So that should also raise alarm bells, whether someone with breast cancer and ovarian cancer or any of the fallopian tube or peritoneal. So that certainly should raise an alarm bell. But individuals with just ovarian cancer alone at any age is also meant in this guideline to have testing, and so on and so forth. And there are pages of this that actually describes who we should test. Now, all of these are based on what we call a priori risk. That means it's already been very well established that these individuals would have around 10 to 15% of being a carrier on the average, but in each individual grouping, then the risk goes higher. So if someone has breast and ovarian cancer, then the risk can be up to 45 to 50%, and so on and so forth. Now, so this is based a lot on the tumor type, on the family history, the age of onset, and the subtype of the cancer. Now, I would also like to highlight that in the more recent years, there are new additions to this sort of guidelines that are very treatment-based. So what they have added on this year is due to new targeted treatments. You can actually do a genetic testing to aid the decision for using these treatments. But this can be anyone with, say, breast cancer, for example. Right? So if it's for treatment purposes, then it doesn't follow the risk criteria. So this is very important because on the one hand, everyone then should be tested if they need to have a treatment option. But on the other hand, if it's someone who doesn't have that initial risk of being a carrier, then it will come as a shock if you do find something in them. So that means the counseling for these individuals becomes very important. So what do we have in Malaysia? So in Malaysia, if we talk about breast cancer, and that in this guideline, it will encompass the ovarian cancers as well. So there are guidelines for genetic testing in Malaysian CPG. So there's an update that was done earlier this year or end of last year, and it has a summary of the criteria, and this simplifies it a little bit, but the main bulk of it still refers to the NCCN guidelines because those are very well evidence-based. So as you can see, there are guidelines and even Malaysian appropriate guidelines to follow for certain clusters of cancers, and this can be looked at across the board depending on what type of cancers that you are looking at. Okay. Then the panels or the genes that you test also becomes very important. I did mention earlier that due to NGS availability, you can now test many genes. So even for cancer, you can test for inherited genes, you can test up till 84 genes, but not all 84 genes will give you clinically actionable information. So it is important to note that if there are any tests that you do, and there are so many tests in the market now, be very careful about what are the genes that are in the panel. Why should you be choosing certain genes? Because it depends a lot on what you're trying to look at. Only in certain cases where you have a broad range of cancers, it doesn't follow any of the classic patterns, then you might do what we call a general cancer risk panel, only in those instances. But if what we have in front of you are clusters, then there are certain genes that are clinically actionable that are meant or provided by guidelines to be tested. So these are the ones that should be used because each of these will have a clinical actionable program that you can have, whether it is for risk management or whether it is for treatment purposes. So it becomes a targeted sort of genetic screen in that sense. I wouldn't use the word screen, the test that you are looking for, very specific to try and identify the inherited risk. So these guidelines are based on publications like these, which are actually in Malaysia, and this is very part of what Cancer Research Malaysia has done. A very, very large international cohort study. So this sort of cohort study gives you the strength or to say with certainty that these are the genes that can cause an increased risk. How much is that increased risk, and across the age platform? So as you can see on the left, those are the odds ratios. So that's how many folds increase in terms of the risk. And on the right, you can see how it increases with age, and it differs between genes, right? So your planning or working with the risk management then depends on what is the gene that is found to be faulty, and that will guide you in your management of the patient. But this is an example of what the evidence is used in order to come up with those guidelines. That's why it's not test everything is always the best. test what gives you the information that you can act on. That would be the main goal of doing a test. So after a test is done, and it's once you've done all of the counseling and so on, I want to highlight that test reports and the interpretation is really, really important when it comes to using genetic information. So a genetic test report is not very just clear-cut yes or no. It will have all of the information about the variant. So if it's a positive test report, so you would mean that you would have found a pathogenic, and it must be pathogenic variant, so that cancer is actually hereditary. It may impact on current or new treatment options. It may impact on risk of other cancers for the same individual, but more importantly, close family members, because these are inherited genetic changes. So we're talking about father, mother, siblings, children, first degree, and so on and so forth. So first degree will have 50% chance of having inherited the same pathogenic variant, and these are in an autosomal dominant fashion. If it is negative, it means whatever you test, there is no variant, right? So the cancer is not likely to be inherited because you would have done your best to choose all of the high-risk genes that are known, but it could be due to it could still be possible due to other genetic factors that are not tested. So for an example, if you have a very strong family history, but the test still comes back negative, does that mean it's not inherited? No, it means that there is a familial pattern. It can be hereditary. You just haven't found a cause, because whatever knowledge that we know now are of high-risk genes, but there's also a lot of data now about what we call polygenic risk. So certain groups of genes that are particular to a certain family could have increased the risk to this family, right? And that pattern is only for this family. So these polygenic risks are not, or scores are a lot are being conducted in research, and they're not used clinically as yet. So you can't have a test for that, right? So negative results need to be interpreted very carefully. It is not likely to change treatment options because you don't have, pairing of what is required for the targeted therapies, but it doesn't mean that there is no risk for the individual or the other family members, because the family history and other type of pointers will then become very important. And it's also very important to note that when we look at genetic variants, we can only understand it well if we know what is the impact on the function of the gene, right? There are many incidents where these variants are uncertain in terms of its impact. So it's literally called variant of uncertain significance. And this is also very common, more so in Asians, because a lot of the large genetic databases are still based on Western or European ancestry type of population. So when we have more and more genetic tests done in Asians, we'll be able to be a bit more accurate in the interpretation. But as of now, there is still quite a high chance of getting a report that says uncertain significance. So this actually puts the information in kind of like in a no man's land. It is not positive, it is not negative. You know there's a variant there, but we don't have enough evidence that this variant has caused a loss in function of the gene. So when you're talking to a patient, this doesn't really make sense, because they would say, you found a variant in my gene. What do you mean? You don't know what it means. So careful interpretation of this type of result is very important, because they cannot use this for medical decisions. So for example, if you have a variant of uncertain significance in a very high risk gene, even so a BRCA1 gene, for example, you cannot use it to remove someone's breast, because we're not sure that that gene is absolutely non-functional. So it is really important to be able to interpret variants well and to be able to decide how it impacts on the function of the gene, and hence the risk of the cancer and the next cancer. So with these reports, what are they actually used for, right? When it comes to inherited genetic information. So as I've mentioned just now, more and more so, it's for treatment decisions. So you look at genetic profiles to try and match it with treatment. You can use for prognosis purposes. You use it to plan what further treatment is necessary or if not based on the prognosis. For risk management, so this is important because this is where you plan how to manage the risk appropriately. And what we call predictive, which is actually cascade testing for relatives in families with known pathogenic variants or mutations. So let's move on a little bit to what I mean by risk management. Why do we need the information for risk management? So for example, if someone has carried a faulty gene in, say, BRCA1 or BRCA2, and we know that it is related to an increased risk to breast and ovarian cancer. So risk management methods at the moment can be things like surveillance or prophylactic risk-reducing mastectomies or prophylactic risk-reducing oophorectomy. So we talk about breast cancer risk. Surveillance is effective. There's a lot of data to say that you can use surveillance for mammograms or MRIs and so on, all depending on the breast density. And it also depends on the, in some way, Asian women and Caucasian women also have a different sort of program for this because it depends on the density of the breast. But similarly, if we are looking at ovarian cancer risk, so the same gene, right, BRCA1 can cause an increased risk to breast and to ovarian cancer. But you can do surveillance for breast, but you cannot do surveillance for ovarian cancer. So used to be that they would do transvaginal ultrasounds and CA125 blood tests, but this is found to be not effective. It cannot really trace or find cancers early enough. So it is not effective, which means for breast cancer risk, we have surveillance as an option or prophylactic surgeries. And we can see that prophylactic mastectomy reduces breast cancer risk for carriers by, it's probably by far the most efficient way. Oh, I seem to have lost one slide. Where is it? Let's go to this one first. And then for ovarian cancer risk, it will have to be an oophorectomy in order to reduce the risk. And this is a very difficult thing to bring up, especially if someone is a young carrier and is still in a childbearing age. How do you tell them that the only way to reduce their risk is to remove their ovaries? So these require very, very careful discussion. So when we talk about genetic testing, it includes genetic counseling because it's a multi-step process. So I would strongly urge that for anyone who is thinking of ordering a genetic test, please think about how it's going to be managed and counseled, how it's going to affect result disclosures, and what to do in terms of the follow-up. So that's where I'll just very briefly describe what the role of a genetic counselor is. So genetic counselor supports and works as part of an MDT in particular. So we use a lot of the information that we have at hand, including family history, medical records, and so on, in order to draw a picture on what the genetic disorder is. So we don't only just work on cancers, it's across the board for genetic conditions. And we do provide support and information to help a person make decisions about testing. We help to interpret the results and to make sure that the understanding of the result is accurate, and discuss about possible treatments or preventative measures and reproductive options as well, because if we're talking about inherited conditions, we will be talking about new reproductive screening technologies. So pre-implantation genetic diagnosis, all of this are part of the discussion as well. So as we move on with new technologies in reproductive options. So that leaves me a little bit of time where I'm going to present case studies in order to describe what I have been talking about as an example. So for the case studies, I'm going to introduce some ideas about how we work with families. So let's have a look at this first family, right? So this is a pedigree. So basically for individuals where we're trying to investigate, we would always try and draw this out, and it's usually 3 generations. So this is a really nice thing to do with your patients. When you see them, to ask them, firstly, the one with the arrow is who we call a proband. So that's the person that you're speaking to. So in this case, the proband has ovarian cancer. Right? So then you will ask, okay, how many brothers and sisters do you have? How many children do you have? Do any of them have cancer? So you go generation by generation. Then you go upwards and then you ask, okay, how about your mother? How's your mother? What does she have? And then you ask, what about your mother's siblings? And then you ask further on, oh, how about your cousins from your mother's side? So as you can see, if you ask in a systematic way, then you'll be able to get the information that is systematic, right? So you will have a drawing, which is like what you have here. Ideally, you would want to have the ages and as much detail as possible, particularly those that are affected, right? So this can be for any of the genetic conditions that you look at, but basically you will need to start with the pedigree first. So I know this proband has ovarian cancer at the age of 50. I have also found out that the mother had breast cancer at the age of 50, and that she has 2 maternal cousins who had breast cancer in their 40s and 50s, right? So if we look at guidelines, even if there's no family history for a patient with ovarian cancer, you would already consider genetic testing, because ovarian cancer is rare, and the chances of an ovarian cancer that is due to an inherited faulty BRCA, BRCA1, BRCA2, or one of the other genes is around 15%. So even without the family history, you would test. But if I look at this family, then I can say, oh, there is breast cancers as well. And the breast cancers are also in the first degree would be the sister, and then 3rd degree are the cousins. Okay, so with this sort of family history, I would already suspect, okay, definitely something is going on. Then I would need to investigate and see, do I know if there are any genes that I should be looking at in particular? Okay, now if we look, there is also a lymphoma, quite a young lymphoma, that is on the right-hand side of the pedigree. Okay, so lymphomas may generally not cluster together with ovarian cancer, but that's also quite suspicious because it's quite young. But on the other hand, it is actually in what we call a nephew. So the nephew will share only 12.5% of the genes with this proband. So it's a little bit more distant. So we are more concerned then about the breast cancers and the ovarian cancers in terms of the clustering. So the question is then, what genetic tests would you order, right? So if you can just choose, I will just give you an option. You can put in the chat box. Would you order a very specific panel that is for breast and ovarian cancer? Or because that's a lymphoma, you'll order a broader panel, which is say up to 80 over genes. What do you think your preference is? I don't know if you can actually take questions here. But anyway, that's a thought for you to think about.
Questions they can put on the chat box. So what genetic testing would you order and who to test? Means who of these family members to test? Okay, so you just have to give them a little bit of time. Okay, so if you can, guys, just answer one question, all three questions of all four. Is the fourth one the question?
Yes, it is. Well, I meant for it to be a discussion. Then I realized that actually I can't
Okay,
have a
so
discussion here.
yes.
So you
So
can
maybe
just
we
put
do
it in
the
chat.
first three questions and then we can see what the answer is and what if anyone answers at all.
So what genetic testing would be? What sort of genes would you consider for a family like that? You know, there anything that pops up? I did mention it before, but might have been too quick in terms of the table. And who would you test? Would you test someone who has cancer? Would you test someone who doesn't have cancer? And why would that be your choice? And if that person is indeed positive, then what do you do with that individual? And who else would you consider having testing in this? I'm not sure if anyone is ready to answer.
Okay, so there is no one answering. Okay, because I think
what do you think? What would you do?
Okay, I think it is very difficult for us to answer the genetic testing to order because when you gave us the list, they were like, you know,
yeah, it was just a table, isn't it?
Yes, it was like watching Sound of Music, you know, where you study do re mi and yet we don't know. It was all like so new to us. Okay, who would I test? Okay, so I would do genetic testing. And who would I test? I would test all the ladies.
Okay, all right.
All the ladies.
Okay. Okay, so let me just come back to this. Yes. So so in this case, sorry, it's gone. Yeah, come back to this first. So because there is a cluster of breast and ovarian cancer, so we will be looking at hereditary breast and ovarian cancer syndrome, which will also include prostate and pancreatic risk now. Yeah, so there is a panel and there will be about 20 genes that are related to the risk of these cancers. So I wouldn't test very broadly, even though I see a lymphoma, not at the moment. I will start with that first. Who to test? Now, for genetic testing, it's most useful to test someone who already has cancer, because you would want to see if that cancer is due to the inherited risk. So you would actually try and test the proband here who has ovarian cancer, right? If some of the other individuals with breast cancer were alive, they could also have been tested as well. So we should always try and think about the person who's affected to be tested first. So in very more and more common actually. So there are situations where
something first. Sure. How much is the testing?
So you can get it around 1,008, 2,000 and above. You know, so it ranges depending on what where you do the test and so on.
Okay, and now that I have cancer, why would you want to test on me?
Okay, so in some situation, it's important to have that profile to match with treatments. So certain classes of drugs only work if there are certain genetic variants. So that's one of the reasons. But also, because these are what we call syndromic genes, so the information may also highlight the risk of other cancers that the person may be at risk to, right? So it gives them more information to manage possible risk for other cancers. Then on top of that, because there is a pattern already, so individuals who are well in the family, right? Like you say just now, you will test all the women.
Yes, sir.
There will be others who may be at risk as well. So the information that is found will then be very useful for other members of the family. So if there is a variant that is found, then other members of the family should consider testing. And because these are inherited, so it will be the siblings and it will be the children, right? Then because it's what we call autosomal dominant, it's a 50% chance that it's passed on to each of the children. And then the siblings will also have a 50% chance of being a carrier as well because they are from the same parents, right? Now, you said something very interesting because you see breast and ovarian cancer. So you mentioned that you would only consider testing for the females, but I may have not mentioned this. So a carrier of the genetic fault, regardless of whether they are male or females, they have inherited risk. It's just that the cancer profiles will be different. So the same gene in a female, for example, can increase risk to breast or ovarian cancer, but the same genetic fault in a male member of the family will increase risk to prostate cancer.
Okay.
So you will consider testing for all family members, regardless of whether they are males or females.
Okay. Now, the risk of, let's say, now we have tested and for all, okay? And for male, it may be pancreatic or prostate. And for female, maybe breast or ovarian. Now, for a healthy person, what would the treatment option and risk management be? Would you take out the breast and the ovary? And will the man take out the pancreas or the prostate? It's not likely, right?
Yeah, so it really depends on the individual and what phase in life they are in. Okay, so the pancreatic cancer risk is not just in men, so women as well will have an increased risk to pancreas if it's BRCA2, for example. Okay, but let's say it's for one of the sisters who will already be in their 50s. So they are past childbearing age, they would have been in menopause. So removing the ovaries, oophorectomy, is a very valid option. So women will consider that. Right? But let's say if it's the daughter, okay, so 1990, so 30 years already, right? But still childbearing age, then oophorectomy would not be something that she would consider. So it depends on the phase in life.
Mastectomy then?
So mastectomy, again, it depends. And also depending on what the gene is and how high the risk is and the age the individual is. So breast mastectomy now have, with good plastic surgery, becomes an option for reconstruction as well. So some young individuals will compare, well, not even young individuals, for any women, they will compare. Do I want to have screening every 6 months? Or do I want to remove my breast, have a reconstruction done, and not have to worry so much every 6 months when I do screening? So the decision is very different for individuals. They have so many other factors that will come into play when they make those decisions. And we also know that a lot of the decisions are not made solely by the woman or the man. It involves their spouse, it involves family members and so on. So decision making when it comes to risk management decisions are varied and they have many factors. So there's a lot of work that have gone in to look at what we call decision aids. So they are like a systematic way for a person to work through what their decision would be. And actually in we've also come up with a decision aid under Prof. Aisha as well for breast cancer risk and ovarian cancer risk for carriers as well. So those are kind of tools that will help an individual make their own personal choice on what they feel they're most comfortable with. And this kind of decision can change over time. So some people may have screening for like 5-6 years, then they decided they want to have a surgery. So it's not something that is decided lightly, and it really depends on the phase of life the individual is in. So understanding what it means to be a carrier then becomes very important. And that is where the family cascade testing is, and working together with this family will then become multidisciplinary team management. So you will have the surgeons coming in, you will have the, for the patient, the oncologist will be involved as well. But for individuals who are unaffected, then it will be more with their surgeons in particular. Okay, so I'm just going to, I have 5 more minutes. I'll just go through the last, second case. I just want to highlight this case where an individual has pancreatic cancer, right? And now with new treatments, this patient would be asked to do a genetic test in order to match with targeted therapy. But the genetic test is an inherited germline test. So this patient may actually find a germline faulty gene, right? Now, if you look at the family history, there's hardly anything going on. Yeah, there's a lung cancer, but it's for someone who is a smoker, and not likely to be as part of the inherited part. So if this person and it happens to be a carrier, the impact it has on this family is actually quite severe, because you are introducing the idea that these relatives and the children in particular will have an inherited high risk depending on which gene, if you're looking at some of the genes, and you have to work very carefully with the individuals who are well, because it's very hard to believe, right, that there's an inherited risk when you don't see any of the patterns at all. But this is possible, and we will see more and more of this because people are having testing for the purpose of treatment, and also not so much based on what their a priori risk or what is the risk that is already in the family. So as we move towards precision medicine, there will be a lot of use of genetic profiling, a lot of use of genetic information, and it's really important that all of this information are well managed in that sense. So, so this was what I just wanted to say. When you test an individual for treatment purpose, the same questions also will be asked. It's just in a very different setting, right? If it's positive, then of course the individual will have a change in treatment, or may have to have risk management, but managing the family when there is no family history, but a known inherited pathogenic variant in this family, then becomes very challenging. So on that note,
yeah, after your summary.
Yes, so in summary, just 5 points that I hope that you'll take away with you. All cancers are due to genetic changes. Yeah, so there must be a genetic change somewhere. So which means all cancers are genetic. The word genetic is not the same as inherited, which is commonly used. Only 5 to 10% of cancers are hereditary. There are guidelines and risk criteria for genetic testing and risk assessment, and genetic tests can be used for treatment options and risk management, but genetic tests really should be accompanied by careful counseling. So thank you very much. And
okay, I have a few.
I am just in time.
Yeah. You did so well with your timing. Okay, let me just ask you, okay, for genetic counseling, okay, I feel like a lot of our GPs can be trained for genetic counseling, don't you think so? Being already a doctor. And
yeah, so there is more and more work international front on how we upskill and also kind of what do you call it, democratize a genetic knowledge, right? So because genetic information is going to be more and more important in the whole treatment pathway. So it is actually important for all non-genetic based clinicians to learn more about genetics, right? So this is what we call mainstreaming. And there are a lot of methods of mainstreaming that are going on. worldwide. So in Malaysia, we have already started with programs where we train. We started with oncologists and gynae oncologists first. As a trial. So there was a study and it's been published. So it's called the MAGIC study, and that's really in the context of ovarian cancer. And basically the genetic counseling is provided by their attending surgeon or oncologist, right? And it shows that there is not inferior in terms of the psychosocial impact to the patient. So it is safe. So it is true that if it's for any doctors, it's not something that is impossible. It requires to just learn some of the skills that are involved in providing genetic information. And
is there a course for them to take?
So there are some online short courses for introductory courses that there are, and I can get some of the details to you for anyone who's interested.
Yeah, okay.
So a lot of it is maybe also due to the pandemic, it's now quite a lot of it are online now. So it's a good opportunity to actually look at some of these short online courses.
Okay, is there any questions? I think usually we will always have questions, but I think this is something very new to all of us, to be honest. Okay, so let's take case 3. Case 3, let's say, is my case. Okay, so now on my paternal side, okay, my father had 10 brothers and sisters, 7 brothers and 3 sisters, and I think so far 8 of them have had cancer. Okay, and of which I think 6 of them have died of cancer. 6. Is it 6? Yeah, most. My dad. 3, 4, 5, 6. 5 or 6 of them have died of cancer. But it's all different cancers. My aunt had breast cancer, but not the usual breast cancer that you get, the less, I think it's intrapapillary cancer. And then 2 had colon cancer, 1 had stomach cancer, 1 had, my dad had vocal cord cancer. My uncle had and 1 had NPC, 1 had stomach, 1 had colon. So actually got 2 or 3 colons, if I'm not mistaken. And then coming down, I had cancer and I had a sarcoma. And my cousin, who is born and bred in Canada, and then she went to Hawaii, and because of the sun, she had melanoma, early melanoma, and she's like in her 30s. So what kind of screening can we do for this?
Yeah, so when it doesn't cluster in particular, so this is when you do a more general, wider kind of test and see what you can pick up. So it might be one of the rarer syndromes. So as you can see, all of the cancer risks that I have mentioned so far are all in ranges, and they are not what we call complete. So you have familial clustering right here, but we may not be able to directly pinpoint it to a single gene cause, right? So it might be what we call a group of genes that are particular in your family that seems to be created for that increase the risk in your family. So it's a stepwise. So you would try and see if you can identify any of the high risk genes first, and in some cases, not all of the cancers are related. So the colons and the stomach might be, the breast and the NPC are probably sporadic. So the clustering may not be, because you have a very big family, right? So there's a possibility that it's a mix of both inherited and sporadic cancers as well.
Well, it's quite bad luck, right? There are a lot of big families,
Yeah,
the
we have seen, I mean, if you want to talk about sometimes luck as well, we have seen carrier families, right? So we know that there is an inherited high risk. So let's say breast, okay? So you would expect that the breast cancer, if we've already found it, so all of the rest of the breast cancers should be because of the high risk gene, right? But we have found families where some of the cancers are not due to the high risk genes. So they did not inherit the high risk genes, and yet they have developed a cancer. So that is not uncommon as well, mainly because we do see more and more cancers now that are the sporadic cancers. We do see more and more. There is an increase in the numbers of cancers. So seeing several cancers that are sporadic, that's in the same family, it is not impossible.
Okay. Jack has a question for pancreatic cancer. Any point screening siblings, children? He said, any point screening children? If defective gene detected, can anything be done to reduce risk of developing the cancer?
Yeah, so if for pancreatic cancer, so only about 10% as well will be inherited. So if it is indeed due to faulty gene that is in the family, then yes, certainly the family members should be screened. Yeah, and for these genes, if there is already an occurrence of pancreatic cancer, so there are actually what we call risk management strategies for the screening for pancreas, and it depends on the age group. So we don't screen children because these are considered adult cancers, right? Unless specifically the gene is actually one of the genes that can incur childhood cancers, then that one is different. Then we will test children. But if it's one of the genes that are associated with adult cancers, then we will only test adults. In Malaysia at the moment, we still only test 21 years and above for these individuals. So if they are adult children, then yes, they will screen. And there are risk management programs. So there are certain scans that can be done, particularly if a pancreatic cancer is already in the family.
Okay, I think we will stop here. For those who cannot scan, okay, just to tell you, you have to watch from a laptop and scan it with your phone. You can't watch with your phone and scan the QR code at the same time. And if you can't scan the QR code for any reason at all, please WhatsApp me. I've given the number. And you can actually give me your name, your IC and MMC and your email, and we will do it manually for you. If you are a nurse and you want the CPD point, do message me. I'll get someone to explain to you how to get the CPD point. So with that, I think we will end here. Thank you so much. And let me see. Oh, somebody just said thank you. So I see you then one of these days.
And we can have a further chat.
Yes,
about your family.
About my family. I think I'm not sure if there's. I feel after the this whole thing and me being in Beacon for the last 1 year, and how often I see patients with two kinds of cancer, and some of it happening at the same time. I have one patient who had stomach pain, pain over the abdomen, and then she scanned and it was sarcoma of the stomach. So she did a PET scan and they found a hot spot over the thyroid, and she also had thyroid cancer at the same time. And just 2 days ago, I saw a lady with lung cancer, and then did a PET scan and found that she had colonic cancer too. So it is quite common.
Yeah. So there are many ways to try and find out why this has happened and what we can do about it.
Well, we cannot do anything about it. Is it possible?
Yeah.
So we can always say life is such and such is life. Okay, with that, good night. Next week.
Good night, everybody.
Okay, next week we'll take a break from Beacon, and we will do a medical legal talk, how to avoid medical legal problems. Our speaker will be P.S. Ranjan, Mr. P.S. Ranjan. So do join us same time next week, Wednesday. See you. Bye. Good night.
Bye, everybody.
Thank you so much.